Good evening. This is Kathleen, and we're going to talk about respiratory. I want you to know, yes, I do know that I left off 1, 2, and 3, and thank you for noticing. Number 1 is identify signs of respiratory distress in a child and an adult. 2, relate direction of tracheal deviation to causative pathology, and diagnose chest wall deformities and alterations of AP lateral ratios. Now, you can see that this says copyright 2004 by Jones and Bartlett. So what I've actually done is take the Kaufman slides, which you have available, and I've kind of changed them a little bit, added a few pictures. As you can remember, I really like pictures. And so that's what we're going to kind of do is go over this and see if I can help you learn to do a better chest or respiratory physical exam. 4, describe the distribution of basic breath sounds, and that's usually, and I can't say this enough, when you auscultate the lungs, you're listening to the anterior and the posterior. A normal recording would be clear to auscultation, CTA anteriorly and posterior, A and P respirations even in labored. But we're going to talk tonight about people who come in with respiratory difficulty. Describe and assess rib motion and dysfunction, and that's probably not a highlight of this. Identify adventitious breath sounds and relate them to pathological conditions. Now, this is relatively easy. If you had in undergraduate school and you thought rails, coarse rails, fine rails, rhonchi, it was very important to be able to discriminate them if they were in the upper part of the lungs, the lower part of the lungs, front of the chest, back of the chest, and to be able to describe those to your instructor. I'm going to give you a simpler approach. Normal air movement is quiet. It's not silent. I had a student once who came to me and said, I don't hear any breath sounds. I think that's good. And I said, no, not good. Let's go recheck this situation out. So normally when air goes through in and out of the lungs, there's no water or there's no space-occupying lesions. So you should hear the same on the right and the left and the front and the back in terms of air movement, depending on if it's the upper part of the chest or the lower part of the chest. After that, if you hear noisy air, you think obstructive air, and you might call it fine rails, and somebody else might call it coarse rails. But what you've said is there's something going on in the chest. Nowadays, we do chest x-rays. We call in pulmonologists. You do a review of the systems, and you come up with a differential diagnosis, and you're already trying to determine, is there an underlying acute or chronic respiratory condition causing a change in those normal breath sounds? So whether you use rails, rhonchi, coarse, fine, that's really not the point. The point is either you have normal breath sounds, meaning you hear the air go in and out, depending on where on the lungs, the inspiration and the expiration ratio. If you hear anything else, then you know there's some pathology and your goal is to find it out. We talk about tactile phragmitis. I think this is one of the easiest skills I learned. And then I use the two-hand approach, put my hands on the back and ask them to say 99. And you're going to feel palpation of the skin through your ulnar part of your hand, and you compare the right versus the left. Percussion, I don't know why, it's very easy for me to percuss. If you're trying to learn percussion, if you have a reflex hammer, sometimes it's just easier to use the reflex hammer on your third digit. Make sure that your first, second, fourth, and fifth digit are not touching, and you hit the hammer to your finger, and then you can hear it. And the best person to practice on is yourself. You can practice on your thigh and hear what that sounds like. You can practice over the bones in your sternum, hear what that sounds like. Go over your stomach so you can learn on yourself what would be the sound. Now I've actually asked patients, what did you hear when I did that, when I'm percussing? What did you hear? What did you hear? And I get them involved in it. And then we'll talk about special testing and the diagnosis of disease states. And the special testing that you use most frequently is chest x-ray. So if anybody ever asks you, if somebody comes in respiratory distress, what's the first test you're going to do, other than a physical exam, it's a chest x-ray. Whether you do a CT of the chest with and without contrast, that depends on what you're looking for, what their kidney function is. But chest x-ray, you can't go wrong with that answer. Now, these are some common respiratory disease that we're going to talk about. Now, we don't talk pneumonia anymore. Pneumonia is what nurses say. As nurse practitioners, you say CAP or HAP, community-acquired pneumonia or hospital-acquired pneumonia. And there's different types. There's viral and there's bacterial. And bacterial, the most common is strep or staph. And then there's your atypical mycoplasma, but that's your pneumonia. The other is pneumothorax, and you can have a spontaneous pneumothorax where all of a sudden somebody goes into respiratory distress and their lung has collapsed. Sometimes this happens after trauma. I'm down here on the beach and people hit the water skiing, and all of a sudden they can't breathe when they get out. I had a 84-year-old that came in last week, had spontaneous pneumothorax. Just woke up in the middle of the night and his lung has collapsed, and after 7 days on a chest tube, it didn't go back up, so they had to go in there and do fix that surgically. So pneumothorax. The other is pleural effusion, and you're going to see pleural effusion on chest x-rays all the time. It usually coincides with some lung pathology that's chronic in nature and or chronic heart disease. And depending on the size of the pleural effusion and how effective their breathing pattern is, then somebody's going to go in and tap that. Now, it depends on your hospital, if that would be your interventional radiologist or a surgeon or a pulmonologist. It depends on how you code that and how that's reimbursed. In the state of Alabama, nurse practitioners can't do that. They can do some thoracentesis. There's a nurse practitioner who's actually married to a pulmonologist, and she goes in there and does that with him. But usually you can't do that. And then COPD. And when I discuss COPD, when I was in college, COPD was the endpoint of three diseases: asthma, which is considered reversible, and then emphysema, which is a byproduct of smoking, and then chronic bronchitis, which is also smoking. Those are the main criteria: is smoking for bronchitis and emphysema. And then asthma went out of favor because asthma is considered reversible. And then somebody said enough asthma and bronchorestriction, and you have some changing or scarring of the lung function. So then you have some areas that is non-reversible. So then you end up with COPD. And it doesn't matter whether you call them the pink puffers or the blue bloaters. COPD usually on a chest x-ray has a flattened diaphragm, and they come in. Now, another common respiratory disease is obstructive sleep apnea, but we're not going to talk about that. So when you look at this, you think history and inspection, meaning look at them, palpitation, percussion, and auscultation. Once again, I wish we could say that there was reliability between two people about what they see and hear in a person, and there isn't, so that's why we have x-rays. The techniques we use in assessing respiratory system are inspection, auscultation, palpitation, and percussion. Inspect, you look; auscultate, you hear; palpitation and percussion. You may choose to do auscultation at the end. Usually when I auscultate the lungs, I then turn around and auscultate the heart and the stomach, and then I proceed to percuss and palpate on the front of the chest, because you're not supposed to, supposedly, auscultate the abdomen after you touch it. So you have to figure out how you can do that when you're doing a focused exam on the core or the body of the person. Remember to auscultate on the abdomen before you percuss or palpate. And that's just the easiest approach for me. I listen on the back, then listen on the front, and go down to the abdomen. Once again, palpation and percussion are not tools that are examination techniques that are used very often. But if somebody comes in your office and they have a respiratory complaint, or you're in the intensive care unit and you're trying to determine what's going on with them, percussion and palpitation can provide information for you. The more you do it and the more range of experiences in persons you do it with, whether they're tall or short or fat or thin or young or old, you'll get a feel for what is considered or your ranges of normal and then what is abnormal. So the first thing you do is inspect, but how you inspect starts with your chief complaint. The more information you can find out with your PQRST and your old cart, the better off you are. You have to ask focused questions. What's your shortness of breath about? And you have to ask how far you can walk. What happens when you walk that far? What do you mean by shortness of breath? What do you mean by a cough? When do you cough? What are the triggers? What makes it stop? You have to ask those questions. And the more questions you can ask, the more information you can come up with so you can start your differential diagnosis. And you do it in a way that's calm and reflective to the patient. So you show that you're patient-focused and you're concerned. It's nice if you pause after your question for the patient to answer, and it's not a rapid fire like a machine gun in terms of your questions, but you want to find out as much information as you can. Note the patient's position of comfort. What that means is sometimes when people come in and they're short of breath, they can't sit up. So they're bent over, or they have their knees to their chest, or they're laying back in the bed, or they're laying on their side. So that obviously is a dead giveaway. If you go to lay them flat and they can't, you have to elevate the table, or they can only sit in the chair, then that's a reason for you to think there is respiratory distress, which means that that's an immediate concern for you. Respiratory distress is an increase in respiratory rate. We say 12 to 20 is the average respiratory rate. 20 is probably a little faster. And what I do is say if they can't finish a normal sentence without taking a deep breath, they're in respiratory distress. There's shortness of breath. They can't breathe. They can't talk and breathe. They can't eat and breathe. With or without the use of oxygen, they're not breathing. That's a tip-off that something is either acutely changed or they have end-stage severe COPD. If they use open mouth breathing, I don't know. Depending on who you read, 70 to 80% of our air comes in our mouth. I've told some patients just put their O2 cannula in their mouth. They're probably going to get more air that way. It has to do with your adenoids and your tonsils and the shape of your mouth and whether you're a smoker or not smoker. So if you see something in a patient, and you can always say, do you always breathe that way with your mouth open? Is that the easiest way for you to breathe? Once again, when you're doing an evaluation of your patient, you're trying to determine what is the change in the patient's status. So you have to find out what is the normal way they do things. If they use an exaggerated chest wall motion, and this is use of accessory muscles, so you have to watch. Now, if you live in a place where people don't take their coats off or they're padded with sweaters, it's much harder to figure out if they're using their accessory muscles. So you might have to look from a few different angles, or you can always ask them, are you using more energy to breathe? Remember that the work of breathing is very calorie expenditure. And that's why those COPD patients usually have wasting of the muscles in their extremities and their temporal area, because it takes them so much energy to get air in and out of their body. Cyanosis, I'm not really big on this. There's central cyanosis and peripheral cyanosis. It depends on your ethnicity. If you find cyanosis or paleness on your sclera or your conjunctivi or the inside of your mouth, I'm not one who does capillary refill on your fingers. So where I am, most people have fake nails, so I can't get that anyway. Or they have blue or purple or some color of the nail that doesn't allow me to examine the nail bed. So if somebody comes in and their lips are blue, that's kind of a dead giveaway. But other than that, I think it's difficult to determine cyanosis. So maybe this is something you want to talk about with your preceptor. What do you think about central cyanosis and peripheral cyanosis as a sign of respiratory distress in a person of any age? Forward leaning. Once again, unless they have back pain, and you're going to meet a few people with chronic or acute low back pain in the family nursing, in the family practice setting, but you want to know when they're leaning that way, is you can say, is that the way you lean to ease the work of breathing? Children present in a different way than infants than do children due to the elderly. And so the infants may be cyanotic. They may have nasal flaring. And once you see that, you really see it. They have abdominal breathing. They have grunting. They have an increased respiratory rate. Usually you have the parents or the significant others or the family or the child caregiver who is telling you that they're not breathing the normal way they're breathing. So signs of respiratory distress in the child is tachypnea, and this is PNEA is air, and TAC is increased use, and so it's an increased respiratory rate. Use of accessory muscles, their whole body is involved. They have nasal flaring. They can't get comfortable because there's no way they can expand their lungs. They have grunting and cyanosis. Now, respiratory distress in the elderly person who has a chronic respiratory condition is entirely different. Can you remember when you were in school and they talked about what is acute respiratory distress? Is it a PCO2 is it above 50, below 50, and a CO2 of above 50, below 50? And they talked about if you gave too much oxygen, you would decrease their hypoxic drive and they would die, and that's not really true. But you learned that when you got out of school. These people are used to being short of breath. And so when they come in and say they can't breathe, they may not have nasal flaring. They may not have tachypnea. What they're doing is they spend so much energy staying still so that they have the energy to work of breathing that you have to go with what they say. They're going to say, I can't breathe, and your goal is to believe them. Vital signs, use of accessory muscles. Now, your use is dependent on your gender. Males breathe from their abdomen. It depends on the size. If you have enlarged breast, I'm not quite sure what that is, B, C, D cup. It may change the way you if the person you're examined has more, I don't know what's the appropriate word, more musculature on them, it may be harder for you to identify use of accessory muscles. Once again, if you're having trouble determining that, you can ask them. Obesity is an ideal body weight of 30% or above, and I think morbid obesity is 40% of above. And when these people walk in your office, it may take them 5 or 10 minutes to settle down and lose their shortness of breath. So when you come in, respiratory distress may not be their problem or why they're seeing you, but you can see that being their size and shape, that ambulating with any distance does cause respiratory distress. Skin and extremities, once again, cyanosis, pallor, cherry redness, or clubbing. Now, let me give you my view on clubbing. And recognize these are my views. Yes, I do read all the time, and I do read daily, Journal Watch, American Family Physician, and Up to Date. But I read things, and I remember what I think I already know. So I don't always remember things that challenge me. So here's how I see it. And so if you talk to a preceptor that doesn't go along with what I say, remember there's various viewpoints on what I'm saying. So usually when you see clubbing of the fingers, unless that person has cystic fibrosis and you know that they've had a chronic respiratory problem as an infant, that clubbing may be genetic. You've met some people that have clubbing of their thumbs and it runs in the family. So that's what you want to know when you look at the clubbing of the fingers is you want to know, have your fingers always looked like that or is this new? So is it genetic, always looked this way, or is it acquired? Has this come on in the last few years? Now, I have actually looked up how long does it take for hypoxia of the fingers for them to change their shape and become clubbed, and I don't have that answer. Maybe you have that answer, and if you do, feel free to put it in the discussion area. Trachea observation. It's normally midline, and here's what you want to know. If you look at it and it's deviated, if it's deviated toward the pathology, that's your double A's, atelectasis, agenesis of the lung, or pneumothorax, pneumonectomy, and pleural fibrosis. If it's deviated away from the pathology, it's chest wall mass and trachea mass. And even though I tell you this, I'm going to ask you, how would you determine what would be the cause of the trachea deviation? And your answer is, I know if you were all in the classroom, everyone would be writing X-ray. So when you have a person with a trachea deviation, you have to figure out, is it acute, meaning a pneumothorax, atelectasis? Have they had trauma, some injury that's changing the way they breathe? Or is there a chronic problem like a chest wall mass, a congestive heart failure, a tracheal mass that's causing deviation of the trachea? So this is the way you look at it. You can put your middle finger there and see, is it midline, is it not? And then this is an X-ray. Once again, you suspect that there's an underlying respiratory problem. You look at the trachea, and then you take a chest X-ray to verify what is the cause of the change in the trachea deviation. So we've talked about inspection, and the book says properly expose the patient's chest wall. I don't know about you, but most of the time I'm not going to see somebody without clothes on. It just doesn't happen either in the office or in the hospital setting. People like those hospital gowns. As lousy as they look, it's sort of like a badge of honor. And so I can't get under them very often. But I have a great stethoscope, and the key to a stethoscope is to get the right earpieces. Mine are rubber, and to put them as facing your nose, and then it completely blocks off your ear, and you can hear. Sometimes you can get a stethoscope where you don't have a bell or diaphragm. It depends on if you press it firm to the chest or away from the chest. But I can hear in 3 layers of clothes. And I've been listening for a while, and I really do listen. I do 4 on the back, 3 on the front, and I tell them I'm going to listen to you breathe 4 times in and out through your mouth. So I rarely expose the patient's chest wall. Maybe you can do that. Obviously, it lends to inspection of the patient's respiratory status, but I don't seem to get that option. And your goal is to be able to assess and inspect with and without clothes. Now, flail chest is a paradoxical movement of the chest wall. It's mainly seen in people who have had trauma. You're going to see it in the ER with people in motor vehicle injuries. And once you've seen it, it's one side of the chest rises and the other side doesn't. It's never a good sign. And then we talk about lateral ratio. There are times, and you saw it in that picture earlier of that gentleman, the AP diameter of his chest is enlarged. You can see that when their clothes are off. They're barrel chested, and that's from them breathing. And you want to know that. Is the AP lateral ratio increased? Most of the time you just see that. You don't have to measure it. You just note it. There's other deformities that you're born in, pectus excavatum, pectus, I can't even say it, carinatum, pigeon chest, and these are bony deformities that actually can change the way you breathe. There probably are surgeries to change the appearance of the chest, but I've seen both of these in young teenagers that I've done exams on. So these are bony deformations of the chest. And this is what some of them look like. Recognizing that changes in the spine, as you see those elderly people with scoliosis and dowager's hump, and that changes the ability of the lungs to expand. So your point is that changes in the back as well as changes in the front of the chest will change your respiratory, your ability to get air in and out. Auscultation, performed over bare good luck skin, usually with the patient seated. I'm always asking patients to lean up in the bed so I can listen to the back. If you don't listen to the back, you're really not doing a lung assessment. If perchance I can't listen to the back when I record my findings, I only say chest clear to auscultation on the anterior aspect. I don't record what I didn't listen to. Once again, stethoscope belongs in your ear in a place that's comfortable. However you do this, if you do the front first, the back next, if you start at the bottom and you go up to the top, whether you do 4 on the front, 4 on the back, 6 on the front, 6 on the back, you have to figure out what works for you, what is considered the standard of care in your practice, but you're comparing the right versus the left in terms of air entry and expulsion, and then you compare how does it sound on the front, how does it sound on the back. Once again, you record clear to auscultation, A and P. You don't say record bilaterally. Now, that's what I say, and everybody around here, that's how they record it. But I know I have many students that record it clear to auscultation bilaterally. So you have to find out from your preceptor what is the preferred way of recording that. You want to ask them to breathe through their mouth and to breathe slowly so that you can hear the air go in and hear the air go out. Now, if they come in with a respiratory complaint, you might ask them to do that very slowly 6 times versus 4 times. And then the point when you're auscultating, if you hear noisy breathing, which equates to obstructive breathing, you ask them to cough to find out if it clears when coughing. Sometimes you end up with sputum or phlegm in the upper airways, so it disallows air going into the lower airways, and that's actually what you're hearing. So if you ask them to cough, it gets rid of the upper airway, not the lower airways, the upper airway sputum, and then you should hear air go in and out.
Dr. Roots.
Yes.
Are you recording this for...
I am recording this. You should have got the message that there's no class tonight. I'm recording this in Wimba.
Thank you so much.
I'm sorry. I heard somebody say something, and I go, my husband isn't in the room. What is this? So you're more than welcome to listen and answer for the rest of the night, but I'm recording it. It'll be available.
Thank you.
You're welcome. I put it in announcements first about 7 this morning. This is auscultation, and this shows you the points that you should listen to. You know that on the posterior, the lung fields go down to the 10th rib, or T10, and then on the front, they go down just below the sternum. So with the auscultation, 3 levels anterior, 2 levels laterally. The only way you're going to hear the right middle lobe is to listen under the axilla or axilla, whichever way you say it, recognizing if you have somebody who comes in with a respiratory problem and you're doing a focused exam, you want to inspect, palpate, percuss, and auscultate all 5 lung fields. Now for respiratory sounds, once again, the basic breath sounds is you hear air. You don't hear anything gurgling. You don't hear anything other than the sweet sound of air going in and out of the body. Anything else is called adventitious. This slide is in the wrong place, but this is when you auscultate and you're trying to figure out if they have these things called bronchophony, whisper pectriloquy, and egophony, and you ask them to say E and it comes out A, and you whisper a word and all this. And this is great to do if somebody comes in and they're patient with you. Once again, it's a great tool and you can use it if somebody's not in respiratory distress, but it's not usually recorded on your physical exam. Once again, now that we have the X-ray and the CT of the chest, most practitioners spend less time listening to the lungs. But it's always interesting when they have pneumonia and you ask them to say E and it actually sounds like A. So initially when I was a nurse practitioner, I did this on everybody. It was just what I did. And it was always interesting to find that out. Now, I've never found a consolidation or a mass on somebody that I wasn't looking for it, but it is interesting. And if you're saying, I don't really know how to do that, if you can get somebody in your family to do this with, and then you say, oh, this is what a normal sounds like, then you can do it with another patient that you know has pneumonia in the hospital, or they have a pleural effusion, and see if it sounds in a different manner. There's also the the YouTube options for you to actually hear this. So we talk about tracheal and bronchial vesicular. And the point of all this is that you hear more air movement on the top in the upper airways than you do in the lower airways. Once again, bronchovesicular, vesicular. And your goal when you listen to the air is there something there that shouldn't be there, i.e. consolidation or fluid. And then figure out how to get rid of it or how to diminish its effect so that the person's able to breathe. Now, the word adventitious means add it. Once again, when you do adventitious sounds, you have to say how loud is it? What are the number of times? Is it on every time they breathe or part of the breathing? What's the timing, meaning inspiration, expiration? What is the location, upper bases, lower bases? What is the pattern? And I'm blanking on the pattern, but you can find that in your book. And does it change with cough? Once again, if you hear rales or rhonchi, you have to ask them to cough to make sure it's not the upper airways, but it's the lower airways that has the problem. We're at the halfway mark, and now I'm going to speed up. Once again, I said before, crackles, wheezes, rales, rhonchi. Wheezes are musical. Not everybody's in respiratory distress. For some of you who have either exercise-induced asthma or adult onset asthma, or you have a child that has asthma, you can hear them breathe. And once again, noisy breathing is obstructive breathing, but they're not always in respiratory distress. But if somebody has wheezing, then there's fluid there, and your goal as a parent or a significant other is to have them use their rescue inhaler or make sure they have a step-up, step-down plan to stop that wheezing. Once again, all of these are the same. Noisy breathing is obstructive breathing. Rubs actually sounds like if you take your hair and you put it in front of your ear and you rub it, and it usually means inflamed viscera or parietal pleura. You have people that come in and they get into that Indian position, that tripod position. They say they woke up, all of a sudden they have pain in their chest. It doesn't hurt if they sit forward facing, and this is usually because they have more space in their lung, and you listen to them, and it is the sound of the pleura going against the chest wall. It's very painful, and it's usually due to inflammation. So your goal is to find out. This happens sometimes after somebody has a myocardial infarction. They end up with pleural inflammation or a pleurisy, some type of lung situation. But once you hear the rub, you're going to hear it again, so it's nice to listen to. It's not nice to produce, I've heard from the patient, but it's interesting for me to listen to. Stridor, you've seen that in people. It's usually in young children, and it usually has to do with respiratory. I see that. You've ever been in a restaurant where somebody has eaten steak that was, the size of their palm versus half of their finger, and it got caught in, and all of a sudden you hear this whistling sound from across the room. I will tell you that I've been in some situations where people have actually gone to the bathroom. They start coughing, they're embarrassed, and they go to the bathroom, and then you find them on the floor. Now, I wasn't there when this happened. And the point is that if you're in a situation and you see somebody coughing and you think they're having trouble breathing, then you would follow them to the bathroom. And because it's easy, sometimes it's easy to do the Heimlich maneuver. I say that, and I've actually done it on a few people, and it's worked. And some people, I had a guy who was 6'6", and I was trying to do it on, and I'm going to tell you how difficult it is. But stridor means airway obstruction, and they really do turn that cyanotic blue if you don't get that obstruction out of the way. These are some adventitious lung sounds. Some of you may learn from hearing. Some of you may learn from visual. I'm kind of a chart person, so I like charts that tell me this. And no, I'm not going to give you, and yes, I may actually give you a test question on this, but it'll probably be worth 1 point and you can match it. Palpitation, you palpate for pain. P for palpitation, P for pain. You do it on the tips of your fingers. They are the most sensitive. Usually you do light palpitation. If somebody comes in respiratory distress, and you start at their back and you lightly put your hand all over their back to see if there's any area of soreness, then you do it under their arms and their chest. And why this is so important is people come in with chest pain. And I worked with cardiac, and we've had 2 patients come in with chest pain, and not until we examined their chest did we understand that their chest pain was actually due to herpes zoster. So that's why it's so nice to be able to lightly palpate and then deeply palpate. So you palpate everywhere, and this is where you're going to find tenderness, bony abnormalities, just something that doesn't feel good. Probably feel normal versus feel good. And then these are the signs of some of the problems with the respiratory distress. These are your chest x-rays, what happens with the percussion, the breath sounds. Once again, it's just another way to look at what we've been talking about. Do I expect you to memorize this? No. This will come with your practice in 680 and your other clinical courses when you can put x-ray pictures with presentations of patients and the differential diagnosis that you've looked up either on Hippocrates or Medscape. Once again, palpitation, pain. Rib dysfunction, we talked about the actual sternum changes or configuration, pectus excavatum, What I'm saying is that there are times when you look at respiratory problems and there's restrictive and obstructive disease categories. Obstructive disease is chronic obstructive pulmonary disease when there's a problem in the lung. You can also have obstructive disease for somebody who is, i.e., pregnant, carries a lot of weight on their chest. You'd find this out through the PFTs and examining the patient. But your goal is that the ribs can influence how to breathe. I talked about tactile phragmitis, and sometimes it can let you know if there's lung, if there's consolidation, or water in an area where there's mainly supposed to be air. There's the two-hand approach and the one-handed approach. I like the two-handed approach. I just ask them to say 99, and you feel the same vibrations on the ulnar aspect of both hands as you go down the back of the chest. And I've done that, and I've actually gone down, and then you're in the right lower base, and you get no 99, and then you go back up, and they do have pneumonia there. So once you have it and it kind of clicks that there's a difference, it's nice to do. I don't see people do it very often in the hospital, nurse practitioners. I see pulmonologists do it, but not other practitioners. Once again, you're trying to find out, is there something other than air in the lungs? Is it solid consolidation, tumor, or is it fluid? And this is a pattern that one might use for tactile phragmitis, one-handed approach. Percussion, I've talked about this before. Even though we talk about it, it's just not used very often. I said I'm able to percuss, and I do hear the sound, but you've got to practice percussion so you can discriminate between what is a solid sound, what is a thud, and what is a bony sound. And these are some examples of percussion sounds. Okay, we're almost there. Now, what are the major respiratory complaints when people come in your office? One is chest pain or discomfort. I have many men who tell me they're not having chest pain, they're having discomfort. And so the goal is not to argue on the terminology, the syntax. What they're saying is something inside my chest hurts. So your goal when somebody talks about chest pain or discomfort is to determine, is it lung? Is it heart? Is it both? Is it going to kill them? And so the main things that kill is a PE or a unstable angina, which is also the same as acute coronary syndrome. And the goal there with unstable angina is STEMI versus non-STEMI. And usually a cardiologist tells you. So that is a deadly chest pain. It can also be pericarditis, which is normally sometimes seen after a myocardial infarction, a dissecting aortic aneurysm. That usually is people present with back pain more than chest pain. And nowadays, they even say at age 50, depending on your criteria, or your smoker, if you're a male, they actually can determine if somebody has an aortic aneurysm, and they follow that. Okay, I'm going to ask the people that are in the class. Here's the thing is I sent out an announcement saying that I'm recording the class tonight, and you can listen anytime you want. And then I sent you the PowerPoint in the mail, so you're not late. I'm actually recording this. And then chest wall costochondritis that Ellen talked about last time. We talked about herpes zoster. When people come in with chest pain, and I've worked with cardiology, the only thing that a cardiologist is going to tell you is it cardiac or non-cardiac. If they do the troponins and they're negative and they look at the EKG and their Framingham risk factors for cardiac event is low, and they consider it non-cardiac, then they walk out the door. And the differential diagnosis for chest pain is about 47. The most common cause of chest pain, if it's not cardiac, is esophageal spasm. Now, people will say, I took a nitroglycerin and it helps. And nitroglycerins do help esophageal spasms, but reflux is a common cause. And then you could have neck problems, gallbladder. Gallbladder isn't always in the right upper extremity postpartum. When you talk about gallbladder attacks, you talk about the F's, fat, 40, flatulent, fad diet, female, but not everybody meets that criteria. So it's just another presentation of what I've just said. We always look at life-threatening causes when somebody comes in with chest pain. You want to determine respiratory, cardiac, or a combination of both. Other respiratory complaints are dyspnea and shortness of breath, and those two terms are interchangeable. And this is when somebody's aware of their breathing, and it's inappropriate to the activity. If you've ever run a half marathon and you're at the finish line, you can say some people are breathing regular, and some people definitely have dyspnea and shortness of breath. But it was appropriate for the activity. Now, if you get up and you walk to the a unisex bathroom from your office chair and it's 5 feet away and it takes you 5 minutes to catch your breath, then you're short of breath. So when people come in with shortness of breath, and I'm going to show you I have some further slides on it, your goal is to determine the severity based on the patient's level of activity. How far do you normally walk? How long does it take you to recover breathing? Are you on oxygen at home? Do you wear oxygen at home? Are there smokers in the house? Do you smoke? Have you been around any chemicals lately? Is somebody repainting the house? And you just have to ask these kind of questions. The other is cough. Sometimes it's respiratory, sometimes it's cardiovascular. There's acute cough and chronic cough. You'll talk about more of that in your other courses. Usually it's due to acute or chronic inflammation, influenza, upper respiratory inflammation, or it can be due to a neoplasm. The neoplasm, you have a lung cancer and all of a sudden it's obstructing the bronchus and they can't get food down, and every time they go to eat, they start coughing. Or it can be started heart failure or a pulmonary emboli. Somebody has surgery and 3 days later they have a hysterectomy and they go home, and 3 days later they have this dry chronic cough that starts in the middle of the night, and it's actually the presentation of a PE. Or irritating particles, gases, or chemicals. I'm really very sensitive to perfumes, and we have a few patients that wear this perfume I can't stand, and when they are around me, I start coughing. In other words, I've had an irritant go to my lungs. I'm also allergic to cats, so when I'm around cats, I begin to cough, and you might find that. So with the dyspnea, your goal is to find out how short of breath they are in normal activities. And then is this a respiratory distress syndrome? Is it something you need to call a pulmonologist today about? Get a chest x-ray right now, get them in to see somebody? Or is this dyspnea, short of breath, multifactorial because they've sat on the couch for the last 6 weeks, gained 20 pounds because their significant other broke up with them and they're eating, trying to deal with their discomfort. And I say that with comfort. There are many people that have life events that they have trouble dealing with, and so they change their activity for a week or a couple of weeks, gain a few pounds, and it really does make them short of breath. Once again, when somebody says short of breath, you have to determine the severity. So here's a fish saying he's a little short of breath, which is much more important than if you run a half marathon and then you're a little short of breath at the end. Here's another dyspnea algorithm for those of you who like algorithms. We talked about cough. There's a chronic cough, an acute cough. You have to find out if they're a stridor with the cough. And now the goal when you cough is not to cover your mouth with your hand or your Kleenex, but to cough in your elbow. And I see people do this in the hospital all the time, and it makes me chuckle. The other respiratory complaint is hemoptysis. This is so we talked about chest pain. We've talked about cough. We've talked about dyspnea and shortness of breath, and now we talk about hemoptysis. The most important thing for you is to find out the source of bleeding. Have they had a tooth removed? Do they have a sore in their mouth? Have they been doing something, putting something in their mouth that would cause irritation? So they would be bleeding. Have they doing cocaine so much that their nose is bleeding going down in their mouth? And that's what they're throwing up because you think hemoptysis is not normal and you're thinking cancer if they come in with hemoptysis. And then just briefly, if somebody comes in with acute respiratory distress, you think of pneumonia, community acquired, hospital acquired. There's lots of scales out there that tells you when to hospitalize, when not to hospitalize. But your goal is when somebody comes in with acute respiratory distress is to determine is pneumonia on your differential. Chronic respiratory problems is asthma. Asthma is not one disease. It's a bunch of diseases. It can happen any time in life. It can be related to allergies. It can be related to exercise. Your goal is anybody who has chronic asthma. They have an increase of dying in an asthma attack. Most people are insensitive to their inability to get air to get air out. Once again, asthma is not being able to get air out. It's not getting air in. So they need to have a step up, step down plan, written plan, and to know when to go up or down on their drugs. COPD, there's called the gold guidelines, and it's in stages, and you have to know what stage of chronic respiratory COPD they're in, whether they need oxygen. It's controversial right now if they need antibiotics when on hand and prednisone to take if they have a change in the sputum production or the amount of cough or shortness of breath. I read something this weekend in Prescriber's Letter that says 5 days of antibiotics is just as good as 2-week tapering in an acute exacerbation of COPD. The new guidelines are trying to come out that if a COPD patient is admitted in 30 days after discharge, the hospital doesn't get reimbursed. So I'm sure in your future you're going to have to be very attentive to discharging COPD patients and keeping them out of the hospital, which means you're going to keep them from having acute respiratory distress on top of their chronic respiratory distress. We're almost there. So what can you do as a nurse practitioner to decrease the chance that your patient's going to have respiratory problems that are acute and or chronic? One is tobacco. Smoking cessation, not sensation. You ask, advise, assess, assist, and arrange. It's called the 5A approach. If you have an electronic medical record, you have to put this down every time. It's considered PQRST. You have to ask on every encounter, and here's how I do it. Sir, I noticed that you smoke. Would you like to talk about smoking cessation? If they say no, I stop right there. And then if they say yes, I say, what have you tried? I congratulate them for trying. I said, what would you like to try? Is there anything I can help? So I let them pivot the conversation. The other is immunizations, flu vaccine, pneumonia vaccine, who needs it, when do they need it, meningococcal, there's the trivalent, there's the quadrivalent, there's the one you give to children that they're all getting over the age of 65. If you get it over the age of 50, you can re-up at 60. So the goal is for you to know tobacco cessation and appropriate immunizations. In summary, notice what their chief complaint is. You have to ask questions, 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 questions. You inspect the size, shape, and breathing pattern of the person. You palpate, and you'd like only air to be in there, but you want air trapping and consolidation and a mask, percuss air, consolidation mask, auscultate, anterior and posterior, comparing the right and left side. You have 5 lobes of the lobe. Adventitious breath sounds is added breath sounds. It's noisy breath sounds. It is obstructive breath sounds. Does it clear with coughing? Respiratory complaints, we talked about chest pain, can be cardiac, can be respiratory, can be a combination of the two. The two that are going to kill you is PE and acute coronary syndrome, which is also called unstable angina, which is STEMI, non-STEMI. Dyspnea, short of breath, you have to find out how is that dyspnea and short of breath interfering with their activity of daily living. Cough, is it chronic, is it acute? Acute respiratory problems is respiratory distress, which we talked at the beginning. It presents differently in an infant than it does in somebody with a chronic respiratory problem. And the other is if somebody comes in, if you think they have pneumonia, you have to treat it as respiratory distress. The two most common respiratory problems are asthma and COPD. There are guidelines for both of them. Both of those people need to be staged, and they need to have a written step-up, step-down plan. The other is health promotion. Always ask about the 5 A's in tobacco cessation and immunizations. Thank you so much. Now I have all these people in the class, and I'm going to stop the recording and see if I can answer questions.